So I'd like to go over the 5 and Flex High Five Award winners. I'm going to go through all the nominations first, and then I'll go over the weekly updates next after I go through all of them. First of all, Barbara is a leader on our unit for LPNs. She has demonstrated exceptional bedside skills and is always willing to help. Thank you, Barbara. Regina Cunningham. Regina always has a positive attitude and is willing to help anyone who needs it. Breland Duncan always does what she's asked to do no matter what. She always makes your day more tolerable and is a pleasure to work with. And Breland got 2 nominations. Deborah Gore. Deborah Gore went above and beyond in honor of the baby and I by coordinating a gift. She has always cared for others by passing meds and switching shifts when needed. Thank you, Deborah. Jackie Varela. Jackie is always volunteering to help not only with other nurses but with the techs too. We appreciate her positive attitude. So this one, there's a nomination for the whole weekend crew. I like to call them the Band of Brothers. Some people call them the Pack. This includes Wendy, Kasia, Lisa, Vera, Emily, Jackie, Tierra, Jasmine, Michelle, and Bria. Crew makes working fun, or the crew makes working fun. All RNs and techs work together so well and always get the job done and make sure patient care is top notch. My heart goes out to them for allowing me to be part of their pack for the past 2 years. They rock. Crystal Harrison, for always having something positive to say and willing to help whenever needed. Debbie Hill, being a good charge nurse, we want to thank you for being a good charge nurse and being there for her staff and the patients. Hannah Yunt, Hannah exemplifies being a team player. As charge nurse and with orienting new staff, she is a hard worker and dedicated. Kudos, Hannah. Vera Jackson. Vera helps the unit run smoothly. Lisa, an amazing nurse who makes all patients feel comfortable, also helps the nurse techs. Caitlin Russell, Kat goes out of her way to make sure every patient is well taken care of. And she's had 2 nominations. We appreciate all of the great help in 1523 and 1524. You're an awesome team member. Dana Cox. Dana noticed that another nurse was slammed and she jumped in without being asked to assist the nurse so she could get caught up. Adelisa Kalak always has a very positive attitude, is always so positive, and is willing to go the extra mile to help her coworkers. And finally, we get to our winner, who is Brittany Martin. Brittany is always helpful and kind. She rarely complains about the issues on the floor. She is a team player and a great person to work with. She always takes the time to assist, teach, and ask if she can help. Brittany always goes out of her way to see if anybody needs help. So she had a total of 3 nominations. So we thank you, Brittany. Everybody really appreciates your teamwork and your effort to make sure that everybody is working together as a team and the unit runs smoothly. We really thank you, Brittany. So next I will go over the weekly updates.
I'd like to welcome everybody to the 5Es and Flex weekly update for this week. I hope you all are having a good summer. I know I am. It's been busy. I'm hoping to get done with my master's practicum in 6 weeks, so that will free up a lot of time and energy for me. So I'm really happy about that coming up. So I would like to start by talking about CHG wipes. So techs do a good job at charting when they do the CHG baths under hygiene. I want to ask nurses to, when you chart under the MAR under CHG, to just click, is the CHG bath done? There's a little button at the bottom that says done. Just check that. That's kind of a double check for us to make sure or ensure that this is being done. So the next thing I want to talk about is intake and output, or strict intake and output in particular. This is generally a thing that doctors order for patients that have renal failure or congestive heart failure. And generally, they want more output than input. So they'll put them on a fluid restriction. It might be 1,500 cc's. This is to make sure that they don't drink more than they're putting out. So it's very imperative that we document these things so the doctors understand where the patient is at in their treatment. They will often be on high dose diuretics such as Lasix, torsemide. A number of other diuretics are used as well. But we need to make sure that we're keeping accurate documentation. That means anything in goes under intake, tube feedings, IV fluids. Nurses usually chart that, or nurses always chart that, I should say. Anything that goes in goes under intake. Anything that goes out goes under output. So when they're on strict intake and output, even if they have diarrhea, that would be included in their output, as well as if they vomit. So Breland Duncan is working on a new strict intake and output sheet that we will put up that we can chart on the door. This will specify better than the other sheet, is it intake or output that that we're documenting. So it'll be a lot clearer and easier for us to document. I'd like to say happy birthday to Brittany Martin and Shanita Covington. Brittany Martin's birthday is July 10th. Shanita Covington's birthday is July 12th, so happy birthday. Chastity will be out of the office next week. Lucretia will be the director that will be covering for Chastity. PAL requests have been approved today for the next schedule. There'll be an upcoming break room renovation. So I'd like to thank Kirsten Ryan. She's done a lot of work on researching how to improve break rooms so that they're more relaxing to go to, that you actually can go there and just escape from what you're doing that day. And we have really appreciated her input on this process. So I'd like to also update on a few of the things that Shared Governance is working on. Kasia Wilson is working on a couple boards, but the first one in particular is the picture board for the unit staff members. So she will be putting together a board that will share a little bit about each person on the unit, as well as a picture of them. This is a way to help the unit jive a little bit better and communicate. So Debbie Hill will be working on a process for an eye care champion. This is someone that we will nominate as a shared governance team who really exemplifies the eye care commitments that we make. Debbie's also been very instrumental in ensuring that our shared governance group has an agenda, that we have a plan. She's been working very diligently with this, and we really thank Debbie Hill for this. And I'd like to also thank Vera Jackson, who will be working on employee engagement. She'll be doing a survey with all the staff just to kind of gauge where we're at. She'll also be working with Kasia Wilson with decorating the unit. And I'd also like to, I'm going to go back. Kasia Wilson also has been an intentional round coach. So she'll be going around and she'll be coaching team members and helping everybody out to ensure that we're doing all of the intentional round and bedside around things appropriately. And Jacqueline Thompson will be doing this as well. So we really thank you all for your help. And the rest of what I'll have to share today, if you don't have time, feel free to, take off right now. But I've had a lot of requests for some instruction on sickle cell patients and suicide precautions. So that will be the next things I will be talking about. If you're not interested in that, feel free to not watch that, because it's going to be a little bit longer this time. So I've had a lot of people ask me the question, what is sickle cell disease? First of all, sickle cell disease is an inherited disease. It is inherited from two two people with a sickle cell trait. If you have two of the genes, you have sickle cell disease. So if there's two partners, one has sickle cell trait and the other has sickle cell trait, there's a 1 in 4 chance that their baby will have sickle cell disease. There's a 2 in 4 chance that their babies will have sickle cell trait, and then there's a 1 in 4 chance that they will not have any sickle cell trait. So 100,000 Americans have sickle cell disease in this country. It is characterized by vaso-occlusion, which results in pain and damage to organs. What I mean vaso-occlusion, the veins and arteries are becoming occluded so that red blood cells are not able to get to certain areas of their body, which can lead to disabilities. And it's from vasoconstriction and sickle-shaped blood cells from decreased oxygen to blood. So whenever their cells are presented with low oxygen conditions, their blood forms the shape of a sickle. This is not good for blood flow because it does not move through the veins and arteries very efficiently. It does not roll like regular blood cells. It gets stuck, it sticks into the sides of the veins and arteries, and it eventually can form clots, and it can occlude any portion of their body that needs blood flow. So the other portion of sickle cell disease is hemolysis, which is the breakdown of red blood cells. This results in anemia. We always say sickle cell anemia. It's because when their blood cells are presented with these conditions of low oxygen, they start to sickle and eventually they die. So this brings down their red blood cells in their body so that their body's not able to carry more oxygen to all their body. So it's kind of a deadly cycle. The breakdown results in high bilirubin. Bilirubin is the result of a breakdown of red blood cells. You typically will see it with patients that have yellow or orangish shapes or colored skin. You can also see it in their urine. When they have increased breakdown of this blood, it's hard for the body to get rid of it all at once, and so that's why sometimes you'll see jaundice or orangish colored urine. So complications of sickle cell disease can be acute chest syndrome. This is like pneumonia, but it's a little bit different because when sickle cell patients get pneumonia, it's a lot worse because they are not able to take in as deep a breaths as everybody else. That's why we have them do the incentive spirometer. They're on narcotics, which depresses your respiratory system. But they also have vaso-occlusion to their lungs. Whenever there's damage to an area, the body reacts by occluding the veins. And so it requires much more oxygen for them to get their blood oxygenated. And this can, because of the lack of blood flow, can be much more worse for sickle cell patients. The common one that we see is acute pain crisis. This is what we typically see sickle cell patients come into the hospital for. And it can be a result of a lot of different things. It can be a result of lack of hydration. Sometimes it's a result of the atmosphere being in. If sickle cell patients were to go to Colorado and there'd be low oxygen content in the air, it could put them into crisis. So another complication that we see is chronic pain. When patients are exposed to high-dose narcotics, sometimes acute pain turns into chronic pain, and sometimes that makes it difficult for practitioners to treat the pain efficiently when patients' neuroreceptors are burnt out from the excess pain medication that they're taking all the time. So there's also aplastic crisis, which basically means the bone marrow shuts down. So bone marrow is what the body uses to generate new red blood cells. So if a patient gets too many transfusions, the body says, hey, I don't need to make any more blood. So that's why they try to really diligently use transfusions for patients. Another thing that can happen is the spleen filters out the sickle cell blood, and it can absorb too much of it so that there's very little blood in the system, and it's all sitting in their spleen, which can sometimes result in a splenectomy or removing the spleen. The other common thing we'll see is sickle cell patients will have problems with their joints. Sometimes with their hips, it's what's called a septic necrosis. What happens when bones don't get blood flow for a long period of time is they basically kind of disintegrate and they necrose. This isn't like an infection. That's why they say aseptic. It's not due to an infection. It's because the blood flow has made it so that the bones have broken down and are no longer able to support them. So going to treatment, when patients come in with a sickle cell crisis or pain crisis, they typically will be treated with aggressive IV hydration. This is because it helps with blood flow. They're having an issue with blood flow or vasoconstriction. This helps inflate the red blood cells that may be starting to sickle. Oxygen also is very necessary, especially if they're hypoxic, because if you think about it, when the blood starts to sickle, it is usually related to lack of oxygen to those red blood cells. Heating pads can help out with pain, but if you think about it, the reason why it helps out with pain is because when you put heat on an area of your body, it opens up the veins and the arteries. So this allows blood to flow that normally wasn't flowing before. So that it can help out with pain, because typically the pain is related to not getting blood flow to an area of their body. So heating pads work. The only cure for sickle cell disease is blood and bone marrow transplant. So this can often be pretty risky. A lot of times patients they basically have to suppress their immune system and be on medications that will suppress their immune system so that they don't reject the transplant that they had. So typically patients, particularly patients that have hemoglobin SS or SB, who are very at risk of complications in acute pain crises, will be on hydroxyurea. This is a medication that reduces complications from sickle cell. It does have some side effects. It does decrease the white blood cell count and platelets, and sometimes it can really decrease the hemoglobin as well. So in those cases, they have to back off on the hydroxyurea and find a dosage that works good for the patient. A lot of sickle cell patients start out while they're young on penicillin, especially patients, like I talked before, the hemoglobin SS, the sickle cell SS and the SB type, a lot of times are prone to more complications. So they're started out younger, and a lot of times they continue with penicillin just to have a prophylactic way of preventing infections, because infections can also cause sickle cell crisis. So also, if they've had their spleen removed, that kind of decreases their body's ability to effectively have a good immune system and remove stuff from the body that's not supposed to be there. So patients that have had a splenectomy also a lot of times will be on penicillin. There's a new medication that I'm not all too familiar with, but it's called voxelotor, and it reduces the sickling of blood. So the final thing that I'm going to talk about is the PCA usage. That's the standard of care that we use now for sickle cell patients. Typically, they will use the PCA they shoot for 3 days, because typically after 3 days, the crisis is resolved. So they're typically on a bolus dose, which uses 0.5 to 0.6 milligrams usually every 10 minutes, and they'll have a 1 hour limit of 3 milligrams or 2 milligrams, and this prevents them from getting too much medication. Now, with these patients, since they're at such a high risk of respiratory depression because of the high dose narcotics, they have to wear the special nasal cannula that monitors their carbon dioxide levels. This prevents them from getting too much medication, because if you get too much medication, you stop taking deep breaths, which makes your body retain carbon dioxide. So once this happens, the PCA shuts off. So these are things in place to protect the patient's safety. So also, they're supposed to wear an oxygen O2 sat monitor. This also alerts us if they're hypoxic. So this all is safety measures. If they are not wearing it, we are instructed to turn off the PCA, notify the doctor, and they have to continually wear the precautionary measures if they're expected to use the PCA. And from what I've seen, there's really no exceptions to this policy. There's some patients that might have nosebleeds and whatnot, but in the past we have not allowed, and this is in line with the oncology leadership as well, that there are no exceptions to this policy because it's preventing death, and that's ultimately the biggest priority for us. If you guys have any other questions on sickle cell disease, please reach out to me. I'll be more than happy to answer your questions. I've been asked by a number of different people to go over suicide precautions, particularly for some of the new employees. Some of these things are gone over through HLCs, but it's good to actually kind of reiterate these things so that we're all on the same page. So I'm lumping in homicidal/suicidal into this because that's according to the policy. I've gone through the policy and I've brought out all the things that I think everybody should know. So IVC patients, they will fall under this category because they are a danger to themselves or others. So they're homicidal or suicidal. So suicide patients obviously are a risk to themselves, so they all fall under this category. So when a patient is deemed to be at risk of harm to their self, an environmental search is done. So through this, we call dietary, make sure they get styrofoam trays so that they can't use metal knives or anything like that. Any items in the room that could be sharp or cords are taken away or made it so it's not possible for the patient to use those items. We use green tape to tape over the outlets so that if a patient decides to stick something in there and shock themselves, they're not able to do that. So if you initially have a patient, usually during their admission, their patient belongings are taken and locked up. This includes everything. Now, there's a little bit of a gray area with cell phones. There's nothing in the policy that states they can't have their cell phones. Now, granted, we can establish boundaries. So in the TCU, I believe they have a policy where patients can only have 3 calls a day. This is for a reason. Sometimes these patients will over-abuse that privilege, and they'll talk to family members or friends that will rile them up. So if that is the case, we absolutely need to restrict their phone privileges. So anytime we start precautions for any IVC patient, suicide precaution patient, we notified the AC for the need for a sitter. So for any patient, well, actually any patient that's admitted to the hospital, we do a suicide severity scale score to see if they're at risk to harm themselves. So what this entails are we ask them, are they feeling hopeless? Have they had thoughts of hurting themselves? Do they have a plan to hurt themselves? These are important questions because sometimes people, they have a plan, or so they have suicidal ideations, but they have no plan. But usually on the floor, we treat every patient that has any sort of suicidal ideations under the same umbrella. So, a couple of things to go over. The door is to remain open at all times, except for brief moments for them to use the bathroom not the bathroom, but if there's any personal care that needs to be done in their room that would require some privacy. However, the sitter is never to leave sight from that patient. So they're not to leave the room. This includes if the patient goes to the bathroom. They can leave the door cracked, but they have to visualize that patient at all times. Now, in the policy, it states that we should allow patients to have the opportunity to have a same sex observe them when they're going to the bathroom. Unfortunately, this is not realistic for most patients, especially male patients, because most of our sitters are female. So for these patients, this is a one-to-one observation. It's 24 hours a day within close proximity, so that if there's anything that happens, we can respond to it. So one thing for the nurses and also the techs to observe are when you give patients medications, make sure that you check their mouth after they receive that medication, because some patients will pocket medication, they'll hold on to it, and they'll collect it, and maybe at some time in the future they might take them all at once. And if that occurs, that would not be a good thing. So for precaution record documentation is done for the sitter every 15 minutes per the policy. This will document behavior, safety precautions that we're taking, respirations, observe for items that are potentially dangerous, such as weapons, extra bed linen, furniture in the bathroom, long cords. I've already went over green tape on outlets. So the center is also in control of the call bell. I know this is actually not in the policy, but it's just something that we've thought would be a good idea, because the call bell is a cord, so they can also use that to strangle themselves. So the sitter is to be in charge of the call bell. So we also notify dietary of suicide precautions, and they have special trays for these patients. The other thing is, if the room is dark, we still have to be able to visualize anything that's going on in the room. So I recommend, in the policy states, to have a flashlight to look around the room if the room's dark. So other things we should be doing: if a patient's suicide precautions are discontinued and they're discharged, we should give them information on suicide prevention and give them resources to follow up on. If I have forgotten anything, please feel free to remind me. I will update if I've missed anything, but I thank you guys for listening.